all. This is Dr. Mobeen Sayed from drbeen.com. Hope you're doing well. Today we'll talk about a study that came out of Germany. It's a very interesting study. What they have done is they've tried to figure out what causes the severe cases and what separates the severe cases from the moderate cases of COVID-19. So we know, all of us know, that there is a concept of cytokine storm. So we know that at some point what happens is that the viral damage itself becomes less and the immune system response becomes more. The question is, what happens in the immune system? Why does it become more? So this study reveals at the cellular level that what are the mechanics of the immune system that become dysregulated or disturbed, which then causes the cytokine storm. Although one part of the study is still open, and that is why does this happen in some people is not known yet. But at least at a cellular level, they have revealed what exactly is happening so that there can be drugs, there can be medicines that can target those mechanics and stop them. And I also want to make sure that you look at the Math Plus protocol, because the macrophage activation syndrome, or MAS, that is used as a basis for the Math Plus protocol is a similar thing that you would see in this study as well. So I really love Dr. Paul Marik's approach, that he was right on the point that there is a macrophage activation syndrome, and if we can suppress that, we can suppress the problem here. So let us look at the study. So first of all, here is the study itself. Let me bring that study to you. This is the study. So if you see here, I had spent the day today looking at the study. So it is 26 June 2020. COVID-19 severity correlates with airway epithelium immune cell interactions identified by single cell analysis. So what they have done is that they have gone over a single cell in every patient that they had in the study, and they looked at their various cells. They looked at the receptors on the cell. They looked at the chemical substances produced by the cell. They looked at the responses of the epithelial cells, and then came back and they said, here is what we have observed in case of moderate and severe cases of COVID-19. Very exciting study. So let me quickly show you their basis. First of all, if you look here, their study actually is based or is focused on these two stages of the COVID-19 severity. We all know that there is an asymptomatic stage. They have, in their study, they have included the asymptomatic stage in the mild to moderate stage. I actually exclude them because there are so many people who never actually end up in the hospitals. So counting them is not really possible. But what they've done is, this is a normal scale that we use for the staging. We say that there are a percentage that is asymptomatic. Then there is 81% of the people who are mild to moderately sick with COVID-19. 14% become severely ill, and then 5% become critically ill, and out of those, 3 die. So 3% die. I have a couple of comments here. Number one, this asymptomatic, and they say that in their study as well, that we were not able to reach the asymptomatic patients because asymptomatic patients do not come to the hospital. So we have no way of looking at their nasopharyngeal swabs or their cells. I have one more comment here from me, and that is that they also do not have inclusion of the long haulers. These are those folks who have recovered, but they still have the lingering virus or lingering symptoms. Whatever is the case, is that the virus itself, or is that the immune system still dysregulated and just falling into a chronic state? That is also out. So really, these 3 stages, mild, severe, and critical stages, are the one that they studied. What they wanted to understand was, what is the difference in these populations of the COVID-19 patients by looking at their cells? I love this idea. So here is what they did. The study was on the upper respiratory tract and the bronchial area. So they did not look at the deeper lung tissue itself or the deeper alveoli and the terminal bronchioles or the deeper respiratory system. They looked at the upper respiratory system. And the reason for that was they said there has been many studies that have looked at the lung and the airways in there and come back with the immune system behavior there. However, there was no study that looked at people's nasopharyngeal area, that is nose and pharynx and upper airways, to see what happens in there. And their point is this: to study this, they said that infection starts from here. We catch the infection in our nose and pharynx or in our throat, and from there the infection then goes to the rest of our body. So why not we try to figure out what is happening in nasopharyngeal area, and then we also try to figure out why are some people responding more than the others. Correct? So with this, what they saw was, for our discussion here, they said, look, the upper airways have epithelial cells in them. These are the functional cells of the airway. Plus, there are immune cells sitting there as well. And this is the case throughout the airway. We have epithelial cells, we have macrophages, we have T cell, B cell, mast cells, neutrophils, and other cells sitting in there. And what they said was that their observation is, and we have been talking about it for some time, that the cells talk with each other through cytokines. That is the chemical substances. Remember, hugs and kisses. So the chemical substances are the one way for the cells to talk with each other. And second are the intercellular contacts. Remember, when the macrophage connects with the connects with the naive T cell, they connect through the intercell contact. So that is fine. We understand that. And finally, they say that we observed that at the end of the day, it is the overactive immune system that becomes the one that causes the damage. And we know that as well. So it's just that I'm bringing us on the same page. And keep Math Plus protocol in mind, because the overactive immune system is something that Math Plus protocol kind of targets. Now, what is the study's structure itself? The study has 19 patients. Remember, they went into every patient's nasal and pharyngeal area. They collected the cells from there. Then they looked at every single cell present and the state of the cell. Some cell is inactive, then it became active. Some cell is secretory. Some cell is epithelial, ciliated. So they looked at every single cell. They looked at their phenotypes. They looked at the chemical expressions on them. They looked at the receptors on them. So this was a lot of hard work they had to do. So 19 patients was enough because they were looking at individual cells in them. So 19 patients who were COVID positive, 14 were males, 5 were females. The age range was 21 to 76 years. Median age was 61 years. That is, half of the population was in this range. 8 patients had moderate symptoms of the disease. 11 patients were critical, out of which 2 patients died, unfortunately. Then they also had 5 control persons as well who were COVID-19 negative. Out of these 5, 2 were males and 3 were females. The testing that they did, they used the nasal swab. So the nasopharyngeal tests were done using the nasal swab. They had taken a total of 36 samples from these 24 people, out of which there were 19 who were patients and 5 who were control. They figured out that there were 22 cell types. So look, if you just look at the cell itself, we would have, let's say, epithelial cell, monocyte, macrophage, T cell, B cell, neutrophil, mast cell. So they don't make 22 cell types. So important thing to note here is it's not just a cell type, but the state of the cell. For example, a naive cell is not active yet. Then it becomes a T helper 2 cell. That's a different state. Or it becomes a T helper 1 cell. That's a different state. Or a cytotoxic cell, which is not active yet, is a different state. When it becomes active, that is a different state. So they looked at all of those kinds of states of the cells there. Beautiful work. So they observed 22 cell types. For the respiratory system, that is the lining of our nose and throat and the airway, they found that there were cells which are called basal cells. Basal cells are the stem cells of the respiratory lining. These cells would give rise to other cells when our epithelial cells are washed away. So basal cells were found, secretory cells were found, then ciliated cells were found. They also found a new kind of a cell, FOX N4 positive, that they found only in the COVID-19 patients. The control persons did not have this cell in them. And then they saw ionocytes. So these were all the cells that were present in the respiratory epithelium. Then for the immune system, they found macrophages. We are very aware of these cells. Dendritic cell, if I could put the N here. Dendritic cells, mast cells, neutrophils, B cells, T cells, natural killer cells. We are aware of most of these cells. N, I'll leave the N over here. Then what they saw was, this was interesting as well, that they saw that compared to mild and control subjects, the critical cases had reduced number of basal cells and increased number of neutrophils. So this is an observation. So they are putting up all of their observations here. Continuing on, normal maturity pathway. So there is someone who's saying that you doctors have caused more problems than anything. I am going to block you. And we'll continue. All right, back here. So what they saw was that in the respiratory system, normally what happens is that we have basal cells, which are the stem cells or the cells that would give rise to other respiratory cells. They usually, in a normal healthy person, all of us, they become secretory cell. They start secreting various substances. Then they further evolve and they develop cilia on them or hair-like structures, and they become ciliated cells. When they become ciliated cells, they also develop ACE2 receptors on them. And we have talked about ACE2 receptors for a long time. Remember ACE2 receptors or ACE2 enzyme, it is a receptor for coronavirus, but otherwise it is an enzyme. And this enzyme has an anti-inflammatory behavior. So they have some ACE2 enzymes in them as well. What they found was, in the study, they found that when the immune system becomes active and it releases interferon gamma, remember that is macrophages can do it, the T helper 1 pathway, especially, forget about the macrophages, the T helper 1 pathway, that is T helper 1 and the cytotoxic T cells, they can produce interferon gamma. In the presence of the interferon gamma, what happens is that the ciliated cell actually becomes a ciliated cell with a large quantity of ACE2 receptors on them. A large quantity of ACE2 receptors on them. That is the strange thing, that in the presence of interferon gamma, remember we were talking about interferons yesterday, that interferons enable the neighboring cells to up their defenses. Here we are looking at interferon released by the immune system. We're not talking about the interferon 1 beta, which was released by the cells that are infected. We are talking about interferon gamma that is released by the immune system cells, especially the cytotoxic T cell and T helper 1 cell. When that interferon gamma is present, it causes the ciliated cells or the epithelial cells to have more ACE2 expression. Now, if I connect the dot with the yesterday's discussion of the interferons, ideally ACE2 expression increase would, in theory, help reduce the inflammation, and it is an anti-inflammatory behavior. So what is happening is the immune system cells are telling the other cells to, hey, guys, have more ACE2 on you so that you can have a dampened immune system and you can survive better. But in case of COVID-19, unfortunately, this ACE2 that has increased is going to be used by the virus to get into the cell. Right? So now we have a problem. Immune system is telling the healthy cells to say, hey, have more ACE2. And immune system is hoping that by having more ACE2, the immune system's out of control behavior will be dampened. But instead, the ACE2 is going to be used by the virus to get into the cell, which would cause the local damage, which would only amplify the immune system. So that is one failure of our system to behave correctly, or one clever thing on the COVID SARS-CoV-2 part, that it works with ACE2. Then another observation that they had, and I just talked about it, is that immune system cells asked the ACE2 to be increased. Finally, they saw that it is the interferon expression which causes the genes to open up in the healthy cells, which then cause more ACE2 receptors to be formed. So interferon has something to do here. This is the kind of thing that was not known before. We knew that interferon gamma would activate the remaining immune system, but we did not know at that time that interferon gamma would actually work with the non-immune cells, healthy cells, and increase the expression of ACE2 on them. So continuing on, other observations that they made was, if this is the healthy secretory cell, so this is one of the epithelial cell, in the presence of the disease COVID-19, and in the presence of moderate disease, the cytotoxic T cell, the T cell that is activated, remember, now normally the B cells should be activated, but some cytotoxic T cells are also active, and they are producing perforin genes. They're having the perforin gene open, CCL5, which is, we've talked about that with the leronlimab, interferon gamma that we are talking about right now, tumor necrosis factor. So there is an increased expression of these things. And I'm going to give you a hint here that at the end of the day, when you would listen to this study, and when you're thinking that how do we then manage these kind of patients who may become severe or critically ill, there are two drugs that come to mind. One from the Math Plus protocol, that is methylprednisolone, or dexamethasone from Oxford's, meaning steroids. And the other one is going to be leronlimab, which is the CCL5, CCR5 disruptor. So that is interesting. I did not read the study in the leronlimab context, but once I read it, it was interesting for me to actually see the CCL5's behavior here. So in case of moderate, these things have become increased. In case of critical patients, these cytokines were actually released less, but somehow the cytotoxic T cell had become very, very lethal in them. And they started causing apoptosis of these surrounding cells. Apoptosis means that the one cell tells the other cell to kill itself, or a cell can tell itself to kill itself as well when it finds that its machinery is not working correctly. The result was, there are two results of this interesting behavior of the chemokines here. One is that the cells that are now sick, that is epithelial cells, they are increasing their expression of CCL, CXCL1, 3, 6, 16, and 17. What they're doing is they're crying out to the immune system to send in neutrophils, T cells, and mast cells. That is a severe case. In case of moderate cells, moderate patients, or moderate COVID-19 patients, CCL15 was released more, which caused monocyte and neutrophils to be called. End result in both cases is that we have the immune cells being called to the area of infection. The only difference that we are seeing is the kind of cells that are being called are different, and the lethality of the CD8 cell is different, which may be the difference, which may be the problem that needs to be taken care of. Continuing on, they compared that. Then they had also collected the data for the cells for the lower respiratory tracts too, and they saw that for the critical patients, the lower respiratory tract had the macrophages and the T cells that were much more lethal compared to the upper respiratory tract. And that is why these patients develop ARDS, or acute respiratory distress syndrome. And they saw that these cells in the lower areas, that is the lungs, they were causing much more apoptosis or killing of the normal cells compared to the upper respiratory areas. So that also tells us that most of the time, 81% of the folks develop mild symptoms and they just have some cough and some fever and they're good, because the immune system, when present in the upper respiratory tract, is not as lethal as when it becomes active in the lower respiratory tract by this virus, which is another strange thing. Every day we come across some strange behavior of this virus. So this was another observation they made. And finally, here is their conclusion. And this is where the connection to the steroids and leronlimab can be made. Their conclusion was that in these patients who were severe or critical, at the end of the day, macrophages had become very, very active, number one. Number two, macrophages were releasing lots and lots of chemokines, which we know. Interleukin 1, interleukin 6, interleukin 8, tumor necrosis factor, GM-CSF. Then here, these interleukins are also released. Here, the one that are CCLs, these are ligands. So they themselves are not the chemical substances. These are the receptors for the chemical substances. What we observed was that as the immune system starts secreting these things from the bone marrow, if you see on the right of this diagram, from the bone marrow, monocytes come out. Monocytes then go into the blood system. From the blood, and at the time that the monocytes are in the blood, they have CCR2, CCR1, and CCR5 receptors on them. So these are chemokine R receptor 5, chemokine receptor 1 and 2. Interestingly, as soon as monocyte then comes out of the blood vessel to go to the site of infection, and remember, when a monocyte goes to the site of infection, when it becomes resident, it becomes a macrophage or a dendritic cell. So macrophage is actually a monocyte. When it is in the blood circulation, it is called a monocyte. When it comes out of it and lives in a tissue, then it is called a macrophage or a dendritic cell. And they found out that as soon as the monocyte comes out, it loses the CCR2 receptor from its surface, but it retains CCR5 and CCR1 receptors. And so then they postulated in that study, if I go here, this is the most important part that I think is interesting, as you can see from my, so if you see here, because binding of CCL2, I'm reading from here, or CCL3 to CCR1, CCR2, or CCR5 can induce monocyte recruitment into the lung parenchyma with subsequent differentiation into inflammatory macrophages and consecutive recruitment and activation of additional immune cells and epithelial damage. Now they're saying CCR1, CCR2, and CCR5 might represent promising anti-inflammatory targets for COVID-19 patients. Then they continue, I leave this line here, then they continue, they say, however, we did not observe CCR2 expression in the respiratory tract of patients with COVID-19, presumably because of its rapid downregulation in monocyte as they exit the bloodstream and enter the tissue, leaving, this is the punchline for the whole talk, leaving CCR1 and or CCR5 as potential therapeutic targets. What they're saying is, if I present that once again over here, what they're saying is that as monocyte comes out of the bone marrow and enters the blood supply, it has CCR2, CCR1, and CCR5 on it. And if we can block a monocyte by giving drugs that can block these receptors, then we can block the monocyte or the cytokine storm. The problem is that CCR2 disappears as soon as the monocyte comes out of the blood vessel. So that is not a good target. However, CCR1 and CCR5, they continue to stay on the macrophage now. This monocyte is now macrophage, and we can give drugs that would go and block this and block the behavior of this macrophage. So that was one outcome they saw. The second conclusion is that it is the interferon gamma. It is the interferon gamma that causes increased ACE2 on the cells, which in turn causes more availability of the receptors for the SARS-CoV-2. So this is a discussion. For me, the dots they got connected were that means that Dr. Paul Maddux, remember, he keeps saying just do the math, and he keeps saying it is a macrophage activation syndrome problem. It's an MAS problem. That is the same problem we are seeing here. And then he says that as soon as this happens, you have a 6 hours of window to very quickly give steroids and prevent the patient from degrading into more severe cases. So that is where this is, and not only steroids. I think that they are also saying CCR1 and CCR5 disrupting medicines can also be used. The one that I know is leronlimab. So there's a question that what is a drug for CCR1? I'll have to look for the CCR1 blockers. Yeah, so there's a question here, is CCR5 associated with leronlimab? Yes, so leronlimab disrupts the CCR5 and CCXL5 axis. Again, this discussion was not about the leronlimab. I wanted to make sure that we can look at this study, which kind of tells you that at a cellular level, the respiratory system of the people who are becoming severe or critical, there are expressions of the cytokines and intercellular contacts with special chemicals that now we know, and we can target them to start avoiding the cytokine storms. We knew that there is cytokine storm. We also knew that this is an immune system imbalance, but what exactly precisely is happening was not known. So this is a very interesting study that brings us there. So guys, this is the discussion for today. There is a question here. In a future video, please review the German paper titled SARS-CoV-2 T-cell epitope defined heterologous and COVID-19 induced. Will do. So we'll do that next week. Yes, Luffy has to pitch in, so Luffy is there. So it's not a problem until it enters the lungs. What prevents it from entering the lungs? Are we talking about the coronavirus, Mary? What they saw was that in the upper respiratory tract, it doesn't cause that much of the damage. But once it is in the deeper tissues in the lungs, the lethality of our immune system is increased. So it is not the virus itself being different here versus here. Virus is the same. The immune system's response in the lower respiratory tract is much more lethal compared to here. And that lethal response does little to the virus, it does more damage to us. Absolutely, Rob. Thank you very much for joining in today. All right, guys, so tomorrow is my off. So my eyes are shining. Tomorrow is my off. Please like, subscribe, and share this. And we would meet again on Monday. Meanwhile, please stay healthy, safe, and happy. Love you all. Like, subscribe, and share. And I would see you on Monday. Bye-bye.